So the OMA study is the first joint venture of the relatively young Oncoplastic Breast Consortium and EUBREAST, two European study groups that for the first time managed to bridge over to the US with some big US sites, Sloan Kettering, MD Anderson, Mayo, Duke, and McGill, to look at the very hot topic, very important question: what is the best staging procedure in patients with clinically node-positive breast cancer who turn into clinically node-negative after neoadjuvant systemic therapy? So you want to perform limited axillary surgery to spare them the morbidity of axillary dissection, and there are two options. One is the sentinel node, and the other one is the sentinel and imaging localization of the clipped node, together called targeted axillary dissection. And with this concept, we brought together about 1,400 procedures, about 700 sentinel procedures. We could compare them to 500 targeted axillary dissection procedures, and we could see that the event rate of axillary recurrence was exceedingly low in both arms. There was no benefit for the more extensive procedure, targeted axillary dissection. The only difference we did find was significantly fewer nodes removed with targeted axillary dissection, so there is less sampling of the axillary nodes. However, numerically the difference was small, just one node less, and if this is relevant, that remains to be seen in future studies.